right, good evening, everyone. And I just want to say greetings from the Kingwood office. So I'm really excited to talk to you about PCOS and how it affects your infertility. So I prepared a little bit of a brief presentation to kind of give you a little bit of an overview and a little taste about what PCOS and what are some of the things that we consider. And then from there, I really want to spend a lot of time just answering any questions that you'll have, because I know that sometimes it's you hear a lot of information or Dr. Google kind of gives you some stuff. So let's go ahead and get started and go from there. So first of all, I want to start off with what is polycystic ovarian syndrome, or PCOS as we commonly call it. Well, it's a hormonal disorder that's commonly characterized by menstrual abnormalities and signs of excess male hormone or androgens, okay? And it's actually the most common endocrine disorder affecting women in the U.S., approximately anywhere from like 6 to 15%, so pretty prevalent in our population. It's a clinical diagnosis, and that I think is really important for people to understand. It's a clinical diagnosis, meaning there's no blood test that you can do to determine whether you have it. And what causes it is very obscure, meaning we don't quite know. And there's many different phenotypes or physical manifestations of PCOS. So you have some patients that are maybe heavier and have a lot of hair growth and have irregular cycles, or you might have what we call like lean PCOS. So there's so many different variations, so it's not a one size fits all. So let's go a little bit, dig a little bit deeper and kind of understand how it is that it's diagnosed. So the clinical diagnosis of PCOS is based off of 3 criteria. Just 3, okay? And you have to have 2 out of the 3 in order to meet diagnostic criteria for PCOS. So the first criteria is hyperandrogenism. Remember we talked about that excess male hormone, or kind of like testosterone. So this is not checking your blood work to see if your testosterone levels are high, but it's actually your clinical manifestations of high testosterone, which includes acne, or excessive hair growth, or a hirsutism, okay? So that's the hyperandrogenism part. The next is having oligo or anovulation. So oligo ovulation, which means that you don't ovulate every month, you ovulate less often than that. So maybe like 8 times throughout the entire year, whereas you're supposed to ovulate about 12 to 13 times. Or anovulation means that you don't get your period at all. So it can be up to 6 months or a year, or you might never get your period. So that's the second criteria. The third criteria is having the classical polycystic ovaries. Okay, so I included some illustrations of an ultrasound finding of what a normal ovary looks like, where you have a few antral follicles in the ovary versus a polycystic ovary. So one of the ultrasound findings is you kind of have that string of pearl effect. So these are all antral follicles, and there's obviously a great ovarian reserve here. But this is what would be characteristic of a polycystic ovary seen on ultrasound, okay? So remember, in order to get the diagnosis, all you need is 2 out of the 3. All right, so what does having PCOS mean? Well, PCOS kind of changes over time, meaning what it means to you changes over time. So in your younger age, you're more kind of concerned about your menstrual disturbances, right? So you are basically not getting your period every month or have really irregular cycles. Then you have these potential concerns for the hirsutism, which is that excess hair growth. Contraception becomes really important because you're having this irregular bleeding all the time. And so your doctor may recommend putting you on birth control pills in order to regulate your cycles. Also, your sexual health may also be compromised because of the fact that you're having this irregular bleeding or spotting, and it's kind of unpredictable. And, you get concerned, well, am I not getting my period because I'm pregnant versus I'm not getting my period because of my PCOS? And finally, what brings a lot of us here today is infertility, because if you're not ovulating every month, meaning you're not releasing an egg, then there's not an opportunity for you to get pregnant. If you have, let's say, oligo ovulation, where you're ovulating, let's say, less than 8 times a year, versus the regular woman has in a given year about 12 to 13 times that she ovulates, then you obviously have less opportunities to get pregnant in a given calendar year than your age-controlled cohort. So as women get older with PCOS, now they're kind of having some shifting and complications. So they're more having issues with pregnancy complication, and a lot of that has to do with the fact of not just because you have PCOS, but because of the comorbidities that are associated with PCOS. So a healthy patient becomes a healthy mom. An unhealthy patient, unfortunately, becomes an unhealthy mom. So those are things we have to think about. Quality of life can potentially be impacted because of the associated comorbidities that are kind of paired with PCOS. You're at a higher likelihood of having type 2 diabetes, cardiovascular disease, and there's also this question about whether there's an increased cancer risk, which we'll talk about in a little bit. So this is a very much a multi-specialty approach, meaning that, you know, in the beginning, like adolescents with their irregular periods probably get falsely diagnosed with PCOS all the time. And so kind of working with the pediatric team, working with dermatology to deal with some of the symptoms like the acne or the hirsutism, working with your gynecologist in order to help regulate your cycles, and eventually when the time comes to try to get pregnant, what's the best way of doing that? An endocrinologist, whether it's reproductive, or an endocrinologist who deals with like other endocrinopathies like type 2 diabetes. You have your diabetes doctor, a cardiologist, and then eventually when you get old enough, a geriatric doctor. So now let's spend a little time talking about the menstrual irregularities, okay? So the important thing to know is that there's a wide spectrum of how PCOS presents itself. There are some patients that have PCOS that don't have any menstrual disturbances. They just have the hirsutism and they have the polycystic appearing ovaries. So they have a pretty, what we call mild disease. But with the more severe your menstrual abnormalities, meaning the fewer times that you get your period, if you get your period at all without any medication, the more severe those menstrual abnormalities, the more likely it is that you're going to be associated with increased metabolic risk. So what we're talking about with these metabolic risks, we're talking about insulin resistance, right, which increases your likelihood for type 2 diabetes, high cholesterol, even high blood pressure. So the important thing to know is there are a lot of my patients that come in that have a history of PCOS, and they say, oh, well, you know, in my later years, my cycles tend to get more regular, and that is something that we can see. So there is hope out there, but there's some other metabolic syndromes that we still have to kind of be careful about, okay? So obesity is a big thing, and guys, we live in Texas. This is very prevalent in our population, and you know, Houston is very fortunate, and it has some great fast food places, but obesity is a problem. And our higher that our BMI, or our body mass index, which is basically a simple calculation looking at your height in comparison to your weight, which you can go online and Google and just type in BMI calculator, and you can just drop in what your height is, what your current weight is, and you can find out what your BMI is. So the higher that your BMI, it's associated with the higher prevalence of menstrual irregularities. So that's going to be important and key, because we're going to be talking about some things that we can do to kind of help this. It's also associated with higher hyperandrogenemia, so kind of higher evidence of that testosterone or that male hormone, and also hirsutism, which is that, you know, that excessive hair growth. So increased BMI and visceral fat, so kind of fat that's located around our organs, okay? So that's more associated with people who have more central obesity, so they kind of carry their weights more in their abdomen in comparison to, let's say, their hips and their legs or something like that. It's associated with higher insulin resistance, okay? Remember, insulin resistance is kind of like that precursor to diabetes, so we want to kind of avoid that. And included in the graphics here, we have a little spectrum of what our normal BMI ranges are, what is considered underweight, normal weight, overweight, obese, and extremely obese. So I would encourage all of us, I mean, just as part of the healthy practice, to just get an idea of what your BMI is. And remember, it's not predictive of who you are, but it can give you some important clinical information to let you know if maybe there needs to be some lifestyle modifications. So metabolic syndrome is something that's closely associated with PCOS. So what is metabolic syndrome? So it's a cluster of conditions that occur together, increasing the risk of heart disease, stroke, and type 2 diabetes. So I included some of the components that go into determining whether or not you're at increased risk of metabolic syndrome. And so you really need 3 out of these 5 features in order to technically get diagnosed with metabolic syndrome. So this is looking at your waist circumference. This is looking at your triglycerides, which is checked when you get your cholesterol checked. This is looking at your HDL cholesterol, which is your good cholesterol, your blood pressure, your fasting glucose. Okay, so those 5 components, any 3 of those 5 increases your risk of metabolic syndrome. Long-term metabolic syndrome kind of is that slippery slope leading down to the heart disease, the stroke, and the type 2 diabetes. So if you identify as potentially having 3 out of the 5 things, well, now you know, and now you could take action and help try to reverse that. All right, so let's talk about that cancer risk real quick, right? People always get freaked out about this. So the reason why PCOS increases is associated with the cancer risk is because you're not shedding your lining every month, okay? And so therefore, if you're not shedding your lining and it's just kind of staying there longer, it has a lot of opportunity to morphologically change over time and potentially become precancerous, if not cancerous, okay? So there is a 2.7 increased fold for risk of endometrial cancer, but most of these tend to be well differentiated and have a good prognosis. So that's part of the reason why when you're not trying to get pregnant and you don't have your regular menstrual cycles, it's important to have a withdrawal bleed with Provera every 3 months. Or some people find it easier just to be on a birth control pill, just because that helps kind of regulate your cycles. And so you don't have to think about taking Provera, which is a progesterone that helps induce your cycle. So just little things to kind of tidbits to remember, not when you're trying to get pregnant, obviously, but important things to know kind of prognostically and moving forward. Now, there are different ethnic differentiators that kind of affect your phenotype that you might have with your PCOS. So I included a list including Asians, South Asians, African Americans, and Hispanics, African descent, Hispanic, and then Middle Eastern and Mediterranean. And so people from different ethnicities can have different appearances of their PCOS that are more common to them. There are so many different phenotypes associated with PCOS because it's a very wide general diagnosis. And so phenotypes vary significantly. So the general management of PCOS is basically lifestyle modifications. It's really important to know that you have this metabolic disease. And so it's basically, you need to be more aware, you need to be more conscientious of the fact that lifestyle modifications might be a reality in your world. So any modest weight loss, even if we're talking about 5% of your total body weight via decreased net caloric intake, can definitely help in terms of improving your overall health. But also, we found that women who are ovulatory or anovulatory, meaning they don't have periods or they don't ovulate, doing this modest decrease in weight can be effective in terms of helping them regain regular cycles. So something to try and consider. Managing the menstrual abnormalities, like we talked about, so birth control pills or Provera, which is progestin only, that you can do either every month or at least every 3 months to induce withdrawal bleed is going to be important. For the hirsutism or the excessive growth, you always have your cosmetic measures where you can do anything from shaving or plucking or waxing or whatever to your lasers or your electrolysis. OTPs can help with which are OTPs, are birth control pills, can help with hirsutism as well. You can try some anti-androgens, whether it's in an oral form like spironolactone, or a topical medication or a cream that you have to apply. But none of those things are long-lasting, meaning that when you stop them, you might get a reoccurrence of your symptoms again. The most important thing is going to be managing the comorbidities, okay? So the associated complications with PCOS, it's going to be important that those get managed and that you have regular care with your physician or your primary physician, just to make sure that you're keeping a close eye on things and that you're doing a good job in terms of making sure your blood pressure is looking good, that your hemoglobin A1C, or the average of your blood sugar, is doing well, your cholesterol is fine, all that good stuff. All right, so let's talk infertility treatments now. So modest weight loss, y'all, I know it's hard, but that is one of the things that can really help make a difference, okay? So modest weight loss, I'm not talking about losing 1,000,000 pounds, but even the smallest bit can help, okay? And so don't underestimate the importance of weight loss. Letrozole, which is an ovulation induction agent, is actually the first-line treatment for women who are anovulatory, meaning that you have higher birth rates and the same rates of miscarriage and fetal abnormalities is compared to Clomid. So for all my patients that come in that want to do oral pills and inseminations for their mechanism of getting pregnant, then letrozole is definitely the medication that we prescribe for this, because they had a head-to-head study between letrozole and Clomid, and letrozole just outperformed Clomid. Another name for letrozole is Femara, okay, for anybody who is thinking about that. So in the past, we had used metformin to help improve fertility, and it really hasn't been shown to be effective or more effective than, let's say, letrozole. So we just do letrozole by itself. But metformin does have a role if you do have evidence of insulin resistance, which it can definitely help with that. So now there is a supplement that you can buy that can definitely be helpful, and it's DCI and MI, which have shown promise with evidence of clinical, endocrine, and metabolic improvements, okay? And so it's really important to note that it was a 40-to-1 ratio of these ingredients. So the myoinosol and the D-chiroinosol with a combination of folic acid twice a day, that was shown to be effective, okay? So so you can definitely look this up. I would take a picture, because a lot of the drug companies now that make these supplements, you can find them on Amazon. They put the daily recommended dosage as like 4 times what the studies actually showed. So, you know, you can choose to take it kind of differently than they recommend and take a lesser dose, because that wasn't really what was studied. This is what was studied, and go from there. And then there's always the option of IVF. Okay, so let's kind of go down that route for a second. So PCOS and IVF. So if you want to talk about your silver lining, the silver lining is that you have a great ovarian reserve, okay? And so you are what we call a high responder, and honey, that is a good place to be, okay? So you have a larger ovarian reserve, and that correlates with a larger likelihood for embryo creations, right? So larger likelihood that you can become a mom. So it also, if you want to look at another silver lining, is because of the fact that you have such a great ovarian reserve, that I won't need to use much medications in order to stimulate your ovaries, okay? So that means that I can utilize lower dosages of IVF meds, which, honey, that equals money saved. And, you know, with having a high ovarian reserve, or, you know, being a high responder, with oral medications, you know, you might get a lot of response from your ovaries. So you might get 1, 2, 3, 4, or more dominant follicles, which might lead to cycle cancellation because you have a high risk of multiples. So IVF is a great way to mitigate that risk of multiples, because we're creating the embryos, but then we're only transferring one embryo. So one embryo equals one baby, unless you are the lucky 1% where that embryo splits and becomes All right. Then, I'll end it with talking about one of the things that a lot of my patients with PCOS think about in regards to IVF, which is ovarian hyperstimulation syndrome, which is one of the side effects that you can sometimes develop after IVF, which is basically your body's excessive response to taking the medication, primarily the injectable gonadotropins, or the IVF medications that are used to make the eggs grow. So in the diagram, you see kind of like what I mean by that. So in a normal natural ovulation, you have one dominant follicle that's ovulating. In a controlled stimulation, or in another non-PCOS or non-high responder, you just have a few follicles growing. But in a patient that has PCOS that has a lot of follicles, you might get a lot of follicle response, which increases your likelihood of hyperstimulation. The good part is that your doctor is fully aware that your ovarian reserve, and so we definitely dose our medication appropriately, and we have a lot of tools in our arsenal to help decrease the discomfort or the likelihood of you developing hyperstimulation. So the symptoms tend to be short and short-lived and relatively mild, mostly just some bloating discomfort that usually kind of resolves within a week from your retrieval. So with that, I want to most importantly leave you with a message. With PCOS and pregnancy, it's important to realize that the reason why that women with PCOS may be at increased risk is because of the comorbidities that they may have going into pregnancy. So that would be things like obesity or insulin resistance. So as I said, the more you medically optimize yourself prior to pregnancy, so the better starting point you are, then the healthier your pregnancy is going to be. If you're not in a really healthy position to begin with, then your pregnancy may be a little bit more compromised, and you may be a little bit higher risk. So really, if at all possible, your health should be optimized before conception. And a lot of times, patients don't really know, well, I mean, we don't have to necessarily strive for perfection. Better is okay too, okay? So that's one of the things that you can talk to your doctor about if you want to get an idea of what goals you should be striving for. So in any woman that has PCOS, close observation is recommended in pregnancy because of that increased risk of gestational diabetes and hypertension, which is in pregnancy is called preeclampsia. All right, so with that, I want you all to know that you are so much more than this label of PCOS. And I